speakers. One is Dr. Abdulla KP, surgical oncologist and MD of OnCare, Astra Institute of Oncology. I invite Dr. Abdullah to come to the desk. Next is Dr. Gangadharan KV, medical oncologist and director of OnCare, Astra Institute of Oncology. Please come, sir. Introduction of the speakers by Dr. Prasad.
Respected senior doctors and my dear friends, good evening. It's my pleasure to introduce two eminent speakers for the day today. We have Dr. Abdulla KP and Dr. Gangadharan KV to speak on cancer screening guidelines and evidences, as well as cancer screening status in India. Dr. KV Gangadharan is a well-known figure, well-known name in the field of oncology in Northern Kerala. He has more than 19 years of experience in cancer care. He is currently working as a chief medical oncologist and head of the Department of Oncology in Astra MIMS Calicut. Dr. Gangadharan did his MBBS from Calicut Medical College, completed in the year 1995. And he did his MD in internal medicine from NHL Medical College, Ahmedabad in 2000. Subsequently, he did DM in medical oncology from BJ Medical College, Gujarat and Gujarat Cancer Institute in 2004. His area of expertise include breast malignancies, colorectal tumors, lymphoma, leukemia, and myeloma. He and his team regularly conduct cancer awareness programs, cancer awareness sessions, and early detection camps in Northern Kerala. I welcome you, sir. The second speaker is Dr. Abdulla. Dr. Abdulla KP. He did his MBBS and MS in general surgery from Calicut Medical College in 2009 and 2015, respectively, he completed. Then he did his MCH in surgical oncology from RCC Trivandrum in the year 2020. He has secured DNB in general surgery as well as diploma in surgical oncology. He is trained in laparoscopy and thoracoscopy procedures. He worked briefly in AIMS New Delhi in the year 2016 to 17. He had 1 month observership in TMH Mumbai as well. And he worked in MCC, Malabar Cancer Center, Thalassery for 1 year. He has various presentations and publications in his name in various venues, multiple venues. His special interest in includes breast oncoplastic surgeries, along with gynec, skin and soft tissue oncology, uro-oncology, as well as thoracic and colorectal malignancy. He is currently working in Astra MIMS Calicut as well as in Kannur. Dr. Abdullah will be speaking on cancer screening guidelines and evidences, and Dr. Gangadharan will be speaking on cancer screening status in India. Thank you.
Good evening, all. First of all, I thank wholeheartedly to the IMA Kannur, Rajmohan sir and Suresh sir and all other members for giving a nice opportunity to have a presentation in this occasion. And also, thank you for good introduction. So I'll directly go to the academic part. So we'll be discussing about the cancer care screening, its guidelines and evidences. Okay, sir. I'll go a little further than I think, okay. So cancer screening guidelines and evidences. The screening means we know that most of the time the cancer present in the very advanced stage, either in the loco-regionally advanced or metastatic stage. So to have that diagnosis in the earlier period, or to diagnose the lesion even before it becomes the malignancy, that is the purpose of screening. So it is performing a test or examination on an asymptomatic individual, not in a patient, in a regular interval to a particular limit of the life. It may be a mass screening in the society, maybe a targeted screening to a particular community. Like we know that some type of cancers are common in some community. maybe Ashkenazi Jews, they are having more breast cancer, ovarian cancer like that, and multipurpose screening and opportunity screening. Most of the time, the screening, what we are encountering is the opportunity screening. The patients coming for some other reason, we are advocating and advising and educating them for a cancer screening and make them to do the screening. So when we are going through the cancer burden worldwide, almost 2 crores of new cancers are being diagnosed every year. And out of that, around 10 lakhs die every year. The cancer death is around 10 lakhs every year. So when it comes to the Indian statistics, almost 1.3 millions of new cancers are diagnosed every year. Out of that, around 17 lakhs constituting the breast cancer. So vast majority is constituted by the breast cancer. Why it is important? We can diagnose and screen the breast cancer in the early stage. That's why it is very important. When you're coming to the Kerala data, now Kerala is becoming the capital of cancer. It already have begun the capital of diabetes and capital of obesity multiple times, and now it's becoming the capital of cancer also. When you're comparing the previous data, out of 1 lakh individual, 1 lakh population, as per the Indian standard, around 135 patients are being diagnosed to have a new cancer every year. Per 1 lakh population, 135 patients are being diagnosed by cancer. When it comes to the Kerala, it is more than that. Around 140 to 160 patients are being diagnosed by new cancer every year in 1 lakh population. So it is very high when compared to the Indian standard. Maybe we can say that the Kerala, the longevity and the life expectation is more when compared to the other state, and the diagnosing the cancer screening is little more than the northern states. Maybe that, but still the incidence and mortality also is very high. So why screening? I already mentioned that you can, is there any pointer? Okay. Most of the time, when you're comparing that, the presentation of the disease in the localized stage, loco-regionally advanced stage, and metastatic stage, many of the cancers are being diagnosed in the locally advanced case. We have to prevent that. We have to diagnose all these cancers either in the localized stage or even before that become the cancer. So the principle of screening, the disease should be a burden to the society. Then only the screening become important. It should be a common disease. The disease should have a preclinical phase before it becoming a major disease. And test must detect a cancer than in the routine symptomatic period. And the treatment initiated earlier should give a survival benefit. So there may be a lead time bias. That means all the time the screening may not be good enough. So in the first person, if you're detecting by screening, we can detect the disease at an earlier period than that is becoming manifested by the symptom. So what happens? For example, the patient is going to have a disease at the age of 50. We are screening at the 40 years. Patient is having the disease at the 40 years. We are screening that patient at the age of 50 and we are diagnosing, and the patient is dying at the age of 70 years. If you're not doing that screening, patient is being diagnosed at the age of 60. That means after 10 years only, but he dies at the age of 70 years. But what happened? What we claim that because of the screening, patient got 20 years after the diagnosis. Without screening, patient got only 10 years after the diagnosis. But that doesn't give any importance because that is just a lead time bias. We have detected that cancer early, but we didn't do anything. The survival of the patient was up to the 70 years only. That is what known as lead time bias. That means if you detect a cancer early by screening doesn't mean that that's a good thing. So it should be a scientifically increasing the survival of the patient if you are detecting that cancer early. So there are so many pitfalls like false positive result. So we have to go for multiple tests, biopsies, copies, etc. False negative. So the patient is actually having a tumor, but your screening test says that he's not having or she is not having that cancer. So they become falsely assured. So naturally what happens, even the diagnosis, even the symptoms present, they think that, oh, I already had that mammography. I already had that colonoscopy. So, and I'm sure that I'm not having any disease. So even the symptoms appears, they won't seek an attention. So it gives us a false assurance and delayed diagnosis. That happens. So false negative, false positive, over diagnosis. Some tumors are just come and go, like very low grade prostate cancer that is need not to detect early. So that is the over diagnosis that became a burden to the society and the health system. And lead time bias already mentioned, and interval cancers. Even if you cancer regularly, some cancers are very aggressive that it won't be there in the previous scan, but it diagnosed in between the screening period. Maybe a very high grade carcinoma breast may be detected during the screening mammography. This cannot be detected by the screening, but it is becoming interval during that screening period. So they also cannot be detected by screening. So screening is not the answer for 100%. So well-established screening protocols are there based on the level 3 evidences in breast cancer, cervical cancer, colon cancer, and lung cancer, and to some extent in the prostate cancer and ovarian cancer. So the breast, I already told that almost 25% of the malignancy contributed by the breast, and that can be easily screened, and sometimes it can be prevented also. So this is the mammography. Usually we do the mediolateral oblique and craniocaudal view. And the screening for breast cancer, it is by the X-ray mammography. There are multiple variable guidelines. Many of them says that at the age of 40, you have to start discussing about the screening mammography with the patient. And if they are okay, and if they understand the benefits and demerits of the screening mammography, they can undergo mammography regularly but annually. And up to the 45 to after 45 years, they can go for screening mammography every 2 years. Initially, it was yearly, and after multiple studies, it has shown that 2-yearly mammography also do the same benefit as yearly mammography. So what is the present guideline? Most of the guidelines says from the 40 years, you have to discuss with the patient and start mammography. Up to the 50 years, 40 to 50 years, do annual mammography. After that, you do the biannual mammography. Usually it is X-ray mammography. So what I'm talking is the screening of an individual, not a patient who is having a lump, she's having a lump or any disease, or she's having a multiple family members or close relatives malignancy. I'm talking about a normal individual. She's about more than 40 years. So she has to undergo that screening mammography regularly. So there are multiple phase 3 trial. That means level 1 evidence is there. And the latest one is a UK age trial. What they say is that there was a confusion whether we have to start at the age of 50 or at the age of 40. So what have done that they included patients, individuals from 39 to 41 years. That means only young women only, 39, 40, 41 years only. And they are randomized into 1:2 for mammography annually or no mammography. And mortality at 10 years, there was 83 versus 219. There was a gross difference with a relative rate ratio of 0.75. That means regular mammography at the age, starting at the age of around 40 gives mortality benefit. So yearly mammogram commenced at the age of 40. That is the conclusion from this trial. And there are other patients who are having more risk than the general public. So those lady who are having a mother or a sister, that means close relatives with the breast cancer, or she's already diagnosed with the breast cancer syndrome like BRCA1 or BRCA2 like that. So for them, we have to do a intense screening with the MR mammography. So some lesions may not be picked up in X-ray mammography. So that can be picked in MR mammography. So these patients like BRCA mutated woman or first degree relative with the BRCA carrier, or she's having multiple family, first degree family members with breast cancer like that. And we are having some risk assessment model like BRCA Pro, close model, Gale model. And if that lady is having a cancer chance of risk of more than 20 to 25%, definitely they have to undergo MR mammography to detect even the minute lesions. And for a high-risk patient, what we have to do that annual breast MRI should be done. Along that, annual breast mammography also to be done. Some cancers will be detected more in the mammography than MRI. So what happens, what we do in a high-risk patient, do 6 monthly MRI mammography and another 6 monthly X-ray mammography. That's why yearly they are having 2 screening programs. So this is that very important for high-risk patients with all these criteria have to undergo intense screening by MR mammography. So we'll come to the cervical cancer. That is the second most common cancer after the breast among the ladies. And the most important thing when we are talking about the cervical cancer is it is the only cancer that we can eradicate from the earth. By vaccination and some other method, we can eradicate that cancer. As of now, with the present scientific data, we cannot eradicate any other malignancy. It is a cervical cancer. We can eradicate that malignancy like polio and any other disease. That is the most important thing when cervical cancer is dealt. So this is how we are doing the cervical cancer screening. There are mainly 2 methods because the cervical cancer is caused by HPV infection, there should be, it is the most important prerequisite to have a cervical cancer. There should be an HPV infection. We know that when we are talking about risk factors for any malignancy, there are hundreds of risk factors. So we cannot say that breast cancer is due to previous radiation, or breast cancer is due to some genetic disease or due to lifestyle. But when we are talking about the cervical cancer, we can say that the infection with the HPV is a must. It's a prerequisite for the cervical cancer to develop. That doesn't mean that all those who are having HPV infection will develop cervical cancer. Usually at the younger period, the woman get the HPV infection, 80% of them will regress by its own. And the remaining 20% will be a chronic infection. Among that, a few less than 5% may develop this cervical cancer. So the infection with the HPV, if we are able to remove that infection, treat that infection, that may lead to the eradication of the cervical cancer. That's a very important thing. So either we have to see the do the pap smear by the cervical pap smear. So we are detecting any cellular changes, cytology. That means, is there any atypical cells? Is there any squamous cell carcinoma like that? Or we can do HPV DNA assessment, high risk HPV DNA, mainly the HPV 16 and 18 causes the cancer. So if you are isolating an HPV DNA 16 or 18 or any other strains, you can label that woman to a high risk patient, and you can do the further procedures like a colposcopy, biopsy, and whatever needed for that. So the screening for cervical cancer, again, there are multiple criteria, and what we are following at this ACOG criteria is we have to start the cervical cancer screening at the age of 21. It is not accepted before that, because anyway, there will be a HPV infection in most of the patient. So at the age of 21, we have to start the cervical cancer screening. That is by pap smear only. And HPV DNA test should be started at the age of 30 only, because before that, there is a high incidence of HPV infection. So we have to give a time that let the HPV infection subside its own, then we have to screen for the patient. Because if that HPV infection persists, that woman is at a high risk of cervical cancer. So what guideline says that from the 21 to 29 years, it is a pap smear screening that is every 3 years. And at the 30 years to 65 years, you can do either HPV DNA alone or HPV DNA plus pap smear, that is co-testing every 5 years, or pap smear alone every 3 years. So before 30 years, there is no role for HPV DNA. And even after HPV vaccination, the screening protocol is the same. It is not getting changed. So that is also very important. And if that girl or if that woman is having more risk factors, like she was having that cervical cancer or she was having that diethyl silbustrol exposure, then they have to undergo more intense screening. If the patient is having a cervical cancer, then even after the hysterectomy, they have to undergo the vaginal wart screening. But if the lady has undergone a hysterectomy for a benign disease, there is no need for further HPV screening or pap smear screening. So usually, it is not part of the topic. Actually, the pap smear and biopsy, most of the time, the reports of the pap smear and biopsy is interchanged. LCIL and HSIL is what we call from the cytology report, that is a Bethesda system, and the CAN1, CAN2, CAN3 classification is for the biopsy. Just mentioning that's all. Okay, after the introduction of the HPV screening, is pap smear screening in United States in the 1950s. What happened by the time of 1980s, almost 70% of the incidence was reduced. Cervical cancer incidence was reduced. That's why the cervical cancer is becoming the cancer of third world countries like India. And cervical cancer screening program was started in India also. And there was a study by Gangadharan et al. And that have even single screening in her lifetime showed 50% decrease in the advanced cervical cancer. So the cervical cancer screening has shown that it is giving high benefit of mortality and high benefit of localized disease diagnosis even in India also. There was a POBAXCAM trial, whether HPV DNA testing or the pap smear testing, which one is the best thing. So it has shown that HPV DNA test has detected many more CAN2 and clinically significant changes than the pap smear alone. So HPV DNA test is a better one than the pap smear, but definitely it is costly. So we'll come to the next topic, that is a CA colon. That is another one thing which is increasing alarmingly. The colorectal malignancy is increasing. That too in Kerala, it is increasing in very high in compared to the rest of India. Maybe so many reasons are there. So we have so many tests to detect or screen the colon cancer. The most important is colonoscopy or sigmoidoscopy, CT colonoscopy is there, and fecal fecal occult blood testing, fecal immunochemical testing is there. That means stool-based test like immunochemical test or the blood test, or direct visualization, that is colonoscopy and sigmoidoscopy or CT colonoscopy. And if you're going through the slides, we can see that the specificity, the sensitivity of the colonoscopy is almost 95%. If there is a lesion, that can be picked up by 95% of the time if you're doing a colonoscopy. And the specificity is also very high. It is around 96%. So as of now, the screening protocol is 45 to 75 years. Stool-based test already mentioned, that is FOBT or FIT or even stool DNA test that has to be done every yearly, or stool DNA test every 5 yearly. And flexible sigmoidoscopy or colonoscopy, the colonoscopic guideline is every 10 years after the 50 years. What I'm talking is for the average risk individual. That means those who are not having any of the symptoms related to the cancer. Those who are having the bleeding PR, those who are having melena, this is not the criteria. What I am talking is for the screening for the average individual. So we have to do 10 yearly colonoscopy after the 50 years. And for an increased risk, that means those patients who are having hereditary colon cancer syndrome like HNPCC or FAP, or those who are having a close relatives like first degree relative with colon cancer or rectal cancer, they have to undergo more intense screening. Like in FAP, familial adenomatous polyposis, that individual definitely will have a colon cancer in lifetime. So they have to undergo colon cancer screening at the age of 12 years. And that too has to be done every 1 to 2 years colonoscopy. And most of the time, the prophylactic colectomy is advocated. So colorectal cancer incidence and mortality rates have been declined in the US, likely due to the increasing uptake of screening, and can improve the disease prognosis by identifying the CRC at the earliest stage. It can even prevent colorectal cancer by finding out that adenomatous polyps and treating that polyp by polypectomy through the colonoscopy. So we can treat even before that become the cancer. Definitely that will increase the survival period. Effect of flexible sigmoidoscopy screening, that is in the there was a major trial, PLCO trial, that is prostate, lung, colon, and ovary trial, screening trial, that has shown that there was around 20% mortality benefit by colonoscopy. So this is the one cancer, there is a level 1 evidence with the phase 3 data that colon cancer should be screened. There is a 20% mortality benefit. So we'll come to the lung cancer. That is one of the most common cancer, but unfortunately, many of the time it is being diagnosed at either stage 4, at some time at the stage 3. It's very rarely we get a stage 1 or stage 2 lung cancer. And the lung cancer screening is not advocated in all individual. It is advocated only in the high risk individual. So those who are 50 to 80 years, they are either present smoker or they have quit the smoking during the last 15 period, and they are having more than 20 pack years of cigarette smoking history. So only those high-risk patients are advocated for lung cancer screening, that is by low-dose CT scan. Initially, it was by X-ray screening, and the trial has shown that low-dose CT scan is much better than X-ray screening. So what is the present guideline? It is a low-dose CT scan. The Russian National Lung Screening Trial, LDCT screening reduced mortality in a high-risk population. So again, in lung cancer also, that too in a high-risk patient only, not in the average risk patient. That means 50 to 80 years who are having more than 20 pack years of smoking history, there is a definite role for LDCT's cancer screening. There was another trial, that is Nelson trial, recently published. It was a phase 3 RCT, low-dose CT, that has shown that 24% of mortality benefit. If you are detecting that, if you are screening by low-dose CT, there is a 24% of mortality benefit. That is a very high percentage, and that has to be encouraged. And for LDCT, the problem, most of the time, the problem with the screening, what we are facing from the patient is that it will expose them for the radiation. Definitely, yes, it will expose them for radiation. But when you are comparing the benefit ratio, risk benefit ratio, the benefit is too high. That's why we can ignore that exposure. Not only that, for the LDCT, the exposure is only 1.4 millisievert only. When you're doing a proper CT scan, CT chest for a diagnosis, that is around 7 to 8 millisievert. So it is almost 8 times lesser than the normal CT. And for the chest X-ray, it is 0.1 millisievert, just for comparison. So the radiation exposure is there, but it's not that too high. So we have to encourage in high risk patient, not in the normal risk patients like colonoscopy or mammography. So we come to the prostate cancer. And the routine screening for prostate is controversial. The thing that most of the time, the prostate malignancy is a low grade. It is not going to affect the survival of that patient. So by detecting that prostate cancer early doesn't give anything apart from that anxiety. So if you're detecting a prostate cancer that is not going to affect their life, doesn't add anything. So the routine screening is controversial. So that is what typically known as overdiagnosis. I already mentioned that in the initial slide, overdiagnosis. So there was two major trials. One was the European trial and the other was a PLC trial already mentioned. European randomized study screening for prostate cancer, ERS-PC trial, definitely showed that there is a benefit of mortality benefit from the routine cancer screening. But in PLC trial, they showed that there is no benefit, whether you screen or not screen, the survival is not getting affected. You are diagnosing much more prostate cancer, but it's not giving any survival benefit to the patient. So there are two phase 3 trial, but they are equally contradicting themselves. So the screening for prostate cancer, the best thing is the shared decision making. We have to discuss with the patient whether they have to go for or not, because they should know that the possibility of overdiagnosis is there. But still, if we are diagnosing a high grade prostate cancer, definitely that is going to increase the lifespan. But we don't know, it may diagnose that low grade prostate also. So it won't help them. So screening confers a small absolute benefit for the prostate cancer. So potential harm of over diagnosis and anxiety should be mentioned. So what is the protocol? There is a level C, grade C recommendation only for a high risk patients. For a when ethnicity is concerned, Black American, Africans are having more chance of prostate cancer. So they are educated to have a prostate cancer screening from the age of 45. For the general population, after the 55 to 70 years, 55 to 69 years, there is an education for that. The prostate PSA testing screening is educated from the 55 to 69 years. That two grade C recommendation only. So we'll come to the ovary screening. It's definite. There is no role for ovary screening in an average risk patient. That means for the routine population, there is no role for ovary screen with either CA125 or a transvaginal ultrasonography. But for the high risk patients, that means the BRCA1 patient, BRCA2 patient, that means hereditary breast ovarian cancer syndrome, or those patients who are having close relatives with ovary or breast cancer, they are having a high risk of ovarian cancer. So they are educated for the routine screening. So to have an annual rectovaginal pelvic examination, CA125 testing, and transvaginal ultrasonography. But for these patients, those who are having high risk of ovarian cancer, is educated for the prophylactic oophorectomy than the screening. So till that age, that means 35 years, or till the childbearing is completed, family is completed, they can undergo the routine screening. After that, they have to undergo that prophylactic bilateral oophorectomy. So anyway, prevention is better than cure. I already mentioned that screening protocol, but if you can prevent that disease, that is the best thing. So this has to be practiced. Avoidance of the tobacco, limiting alcohol consumption, being physically active, and maintaining a healthy weight. Diet rich in fruits, vegetables, whole grains, and low saturated and trans fatty acids. Protecting against infection as HPV, HBV, EBV, etc. That infection has to be prevented, and avoiding excess sun exposure. UV rays has to be avoided. There is a no risk for electromagnetic radiation from cell phone or any other major tower. There is no risk of cancer. There are some data that causes a schwannoma, but no data that is causing an invasive malignancy. So cell phones are, as of now, it's not a risk factor. And there is a role for chemo prevention, like aspirins has shown that it reduces the colorectal cancer. Metformin has shown that it reduces the cancer and some other cancer related to the obesity. And tamoxifen prophylaxis for those patients who are at high risk, like lobular carcinoma in situ is there, or atypical hyperplasia is there. For that individuals, if they are more than 35 years, they can have that chemo prophylaxis with the tamoxifen, but it's not level 1 data. We are not routinely practicing, but some data is there. And the most important thing for prevention is vaccination. That's mainly the HPV vaccination and hepatitis B vaccination. And HPV vaccination, the available in the market are two companies are Gardasil 4 and 9. Gardasil 4 means the major HPV strains like HPV 16, 18, and 5 and 6 and 11. 6 and 11 doesn't cause malignancy, but this Gardasil 4 has the antigen for all these strains. And Gardasil 9 is a non-valent vaccine. And there is another Sevavac vaccine by the Serum Institute of India recently introduced in the market. That is the native Indian-made vaccine. So definitely it is going to be a less price than the Gardasil. So the HPV vaccination recommendation is for, as of now, it's for the girls. It is for the 9 to 14 years. It should be 2 doses, 0 and 6 monthly. And girls 15 years and above, it is 3 doses, 0, 1, and 6 months. For the boys also, this vaccination will help to prevent the oropharyngeal cancer, pineal cancer, and anal cancer. There is data in many of the countries have educated the vaccination of the boys also. In even in India, I think in Delhi and Punjab, they have introduced this HPV vaccination in the public vaccination program from 2016 onwards. And in Kerala, the discussion is going on. And quadrivalent vaccine, there is a future 2 study. And this vaccination phase 3 trial has shown that in 15 to 26 years of female, 3 doses of quadrivalent vaccine prevent 98% of the CAN2 and above disease. That means almost 98 to 100% cervical cancer can be prevented by this HPV vaccination. Next comes the HPV vaccination. Now it is part of the protocol in the childhood vaccination. For the adult, there is a catch-up vaccination program administered 3 doses of in the series of 0, 1, and 6 months. So these are the major 2 vaccination. So this is how we have to prevent the cancer and how we have to screen the cancer at the earliest stage. Thank you. So I just want to tell you that it's not the oncure or the some oncologist important. It's the you matter, because you are the person seeing the individuals or the patients. You are referring to the oncologist. So to detect the cancer at the earliest period, or even that become the malignancy, I think other doctors than the oncologist has to intervene more. So it's not the patients, it's the individual, maybe the companions of the patients or relatives of the patients, or the patient who are having some other problem, maybe a patient who is coming for the cardiology problem or a neurology problem. They have to go undergo the screening and to detect if anything is there and to treat at the earliest. That's why you want to say you matter. Thank you. Is there any queries? I think I will address after sir's talk, I think. Sir.
A very good evening to all. Abdullah has given detailed discussion regarding cancer screening and recommendations. First of all, thanks to organizers, Drs. Sadishan sir and Rajmohan sir for invitation. And it's a topic, is a very relevant topic in our day-to-day practice. Because cancer is a common disease. If you go in any clinics, it's one of the common diseases now, cancer. Because incidence and prevalence is increasing. Especially in Kerala, our aging population is increasing. Our infrastructure is increasing. Resources increasing. So naturally, early detection also increasing. So detection of cancer is one of the common thing now. After you're 65, any clinic is one of the common problem, especially the breast cancer, lung cancer, colorectal cancer, prostate cancer, myeloma, lymphoma. It's a common issue. So here the topic is mainly confined to screening. So we think of commonest one is carcinoma breast, followed by colorectal cancer, cervical cancer, lung cancer, head and neck cancers. Here, the most important thing is going everywhere. It is breast cancer is the commonest, because out of 100 female, 35% is breast cancer in any cancer centers. So breast, you should think of, always think of any lady coming to clinics, think of, it's a common problem. Anybody have got any breast lump should be investigated thoroughly, because that's the only way we can detect early. And health education program always confined to breast cancer and incidence issues. Because if you detect early, the outcome is an excellent outcome. Almost if you detect a 2 centimeter lump, then you treat properly, 80% outcome is there. So that is the area we always put in special interest, always take a special notes. Because as a clinician, I am practicing for last 20 years. It's one of the rare, very difficult, challenging, because they're coming with the stage 3, stage 4, and discussion, cost issues, new drugs, new molecules. Once you detect early, that things are totally different. We can give only surgery, usually breast cancer surgery, then followed by adjuvant chemotherapy, hormone medication for 5 years, then follow. That is why the importance of screening is always, I'm as a clinician always interested in cancer detection program, awareness program. if you look for the incidence wise, cancer is emerging, and in Kerala also it's one of the emerging thing. Out of 1 lakh, 135, 140 number is there. Because Kerala statistics is very, now is Kerala is an important state for cancer detection cases. 135 to 140 per 1 lakh in RCC 200 as well as Kollam registry, both are detected this number. So that is the number is very high. And if you look for the common cancer is again, breast cancer is coming up, 13.5% overall 100 cases. Then followed by head and neck cancers, then cervix, then lung cancer, colorectal. Then say especially here again, so, if you look for the male patient, again, if you look for the head and neck is the commonest one. Then lung, stomach, colorectal, esophagus, remaining. In our population, prostate is next. I think third one may be a prostate cancer. The registry is different. That is why they are reporting this way. Otherwise, Kerala, in our populations, we have think of a lung cancer, prostate cancer, colorectal cancer, head and neck cancer, the common things. So here, next time I have discussed breast, but next thing you always think of cervical cancer because in Kerala it is coming down. If you look for the CS cervix is coming down. Last, many registries are showing the number of incidents in cervical cancer is coming down because of gynecologists are actually involving. Pap smear testing is everywhere is going on. Health center is common, community center is going on. So CS cervix is coming down as such. There is because of the awareness, alertness, and active involvement of gynecologists and health center, again, it's involving in the main health centers. Other thing is colorectal cancer is now also difficult because the detect early is very tough because we can say only we actively the doctors are involving to think of colorectal cancer in day-to-day practice. Think of melena or stool occult blood. That is the only way we can detect early. If anybody is complaining of melena, occult blood, we always think of doing an investigation further. Look for the colonoscopy because occult blood is a very non-specific in this our time because the majority of patients are on ecospirin, dispirin. So that is a way many patients are detecting early. Many of the patients are on dispirin. The bleeding is usually 40, 45. They all are diabetic, hypertension, IHD. So on dispirin, though, many of the patients are complaining of occult melena. So we investigate further. One thing is benefit also there. So false positivity is also there. So colonoscopy is the ideal way. Always think of sigmoidoscopy or colonoscopy. If anybody is complaining of bleeding PR or melena, or if anybody is having complaints of persistent, anybody on old age, microcytic hypokalemic anemia, think of colorectal cancer. That's the only way you detect early. Once you detect early, outcome is here also because long incubation period is there. Very good outcome because once you detect properly treated, surgery, radiation. Colorectal cancer, we think of radiation, chemo. Otherwise, colon cancer is hemicolectomy followed by adjuvant chemo, doing very well. Almost stage 1 disease means no need of chemotherapy. Stage 2, no need of chemotherapy, only surgery. Stage 3 onwards, chemo play a major role. So outcome is stage 1, 2 is 80% outcome. 3 is 65%, 70% outcome. So early detection means colorectal cancer, what is important? Hemicolectomy, we can put on follow-up. No need of further treatment. Cost is coming down. Once you stage 4, stage 3, next is chemo. Stage 4 means new molecules, advanced drugs, immunotherapy. Again, cost is coming up. So always think of early detection only policy in our India, because if you detect the early stages, cost is coming down. Treatment cost is coming down. That's a more important thing. Number of new cases in again female always we no need of any discussion. 35% is breast cancer. Then remaining cervix, ovary, oral cavity. That is coming. Main thing is if you take a 50% of female malignancies, breast, uterine cancer, cervix. 50%. The remaining 50% are other group, head and neck, lung, pancreas, myeloma, leukemia, lymphomas. So if you can prevent almost 50%, if you detect properly, we think of awareness, education, community education program, proper detection program, we can detect 50% of female malignancies. Then cumulative risk in developing a cancer of any site in 0 to 74 years age group is 1 in 7 in men, 1 in 9 in females. Again, female cancer is coming up because of breast and uterine cancer. Uterine cancer is increasing now. Because other thing is, main thing is obesity and sedentary lifestyle. Obesity and sedentary lifestyle is other thing is our hormone changes are occurring in the early ages. So that is because of our lifestyle, food habits, That's the reason for more and more breast cancer and uterine cancer. Next is tobacco-related cancers. Again, is high. If you can prevent almost 35 to 40% of all cancer by simply avoiding the cessation of smoking. Once you omit or quit smoking, we can control or avoid or omit 40% of cancer. Then stages of cancer presentation in Kerala is, again, if you look for the lung cancer, 3% is localized, 35% loco-regional, stomach 5% is localized disease, 60% loco-regional where we need to go for a surgery, radiation, neoadjuvant chemotherapy. Head and neck is 25% localized, other thing is locally advanced. Breast cancer, 30% localized disease, recent data, and 50% is locally advanced. So here the detection of early detection is play a major role. In all these malignancies, we can, if you detect early, we can almost cover 50 to 60% of cancer in the early stage. Again, if you look for this curve, once you after age of 60, 65, after age of 60, the cancer incidence is coming up in male patients. Female patient is status quo. We go for the mainly because of lung cancer, colorectal cancer, lymphomas, other is prostate cancer. After age of 60, the incidence is coming up, significantly increasing. This is one of the recent data. Status of cancer screening in India. Alarm signal from the National Family Health Survey. Percentage of women who have ever undergone screening for cervical cancer is only 1.9%. Breast cancer is only 0.9%. Oral cavity is 0.9%. This is a very, the only thing is less than 1% of population going for screening. So only thing we can do this we can more and more help community health education program, give importance, give more knowledge to them. Then only they're motivated to enter into cancer screening programs. And if you look for the United States or Western countries, breast cancer screening in the 60% of the population is involved in breast cancer screening. CS cervix, 45 to 50%. Prostate cancer is 39%. That means they are almost 50 times higher to detecting early. That is why the outcome is better. They are doing well. So reason whatever if they're done an inquiry in the various places, reason for not screening is main thing is knowledge factor. The health education, more and more awareness, more detailed education in the village, urban areas, go into depth to each individual group, NGOs, community program. That is the only way we can improve the cancer detection program, screening program. Next is resources. Again, important things. Manpower is important thing. You need adequate good doctors, staff, and pap smear programming. Here, the main thing is resource, staff, technicians, nursing staff. Everybody is equally important. Other thing is fear, anxiety is other issue. Everybody, once you go into any cancer detection program, main thing is fear come, anxiety come, then controversies. So psychosocial factors, other thing. No response to many things. So to improve cancer screening program, we want to improve our knowledge. We want to improve the frequent education program. Involved in daily practice, it is a common disease. That's only once you detect, think that it's a common disease, we'll naturally inquire regarding this cancer and think of early detection. Thank you for patient hearing. So it's a very interesting. I'm coming frequently. Initially, I am coming to Kannur IMF commentary. Frequently, I am coming. I had come here almost 5 to 6 times for a way. Usually, in that time, myeloma is a common topic for me. And one is my febrile neutropenia. Next time, one session is a breast cancer. See, the topic is totally different. So if we are ready for, again, Abdulla is a very active, involving in a screening program. It's a very enthusiastic surgeon. Again, he's working in mainly Kannur.
Thank you, Dr. Gangadharan and Dr. Abdulla, for the excellent and very informative talk. Now the topic is open for discussion.
adolescent girls, youth and colleges, self-test examination, just get thinking with so that's one point that can be added as a preventive measure in even behavioral problem. Other one what we are doing is small instrument called hybrid examination for community screening is very, very useful. I think it's for a very costly thing. You can do as a credit examination, especially in conferences, we mass program, exhibition, etc. Just
Like those.
and you can see whether there is a tumor or a swelling, maybe maybe a fibroid or something else. So that can also be added in the screening program. That will be very, very patient.
Thanks. And one more thing, I just want to add, in the cervix also, there are some other tests like visual acetic acid test, because this pap smear and HPV DNA may be costly or cumbersome. So this visual acetic acid test is shown to have some benefit. But the problem, as all these are things commonly practiced in India, the scientific data may not be there. So this that handheld torch or that self-breast examination also, actually in clinical trials this self-breast examination doesn't show the benefit, but we know that from our community because they are not at all going to the doctor. So educating them to do at least self-breast examination will definitely pick some tumors. So that may not be important for the American or the some of the Western countries. That's why the data is not showing the benefit, but definitely we know that it has some benefit at least in our country. Thank you, sir.
What's our experience is most of the ladies in our population, they're coming with this age 4, etc. Even with the abscess, the broken down, they're coming. Up to that period, they'll be holding with this some other dress, etc. Holding it. For that community, if you know good touch and bad touch methods in pediatric, all the children we are practicing to prevent the sexual abuse. Like that, if you teach the adolescents or small girls regarding this self-breast examination, it will work wonders. They'll be doing, and as well as they'll be promoting this test to the grandma and all of that. That will be
So,
Western data may not be a very big thing, but for us it is very important.
Our culture is the only thing we can do in breast cancer is importance of self-breast examination. The most important thing is it should be done in all families. We go to each family there, if they are involving to.
Examination is very important because this mammography is not accessible to the total population. You cannot give, is it available not very, and in mass screening, the self-examination is the only thing that we can do. You have to promote that is what is done. Your slide is not mentionable. Now, whatever the surveillance, you got
yeah, that's also there, but I told you that that data is not supporting, but still it is beneficial in our community.
Data we should have to produce. We have to. We should not do it for something. We have to publish it. Every data is out.
Definitely, we have to look that.
There is also human market.
No role for the tumor markers except prostate. Prostate, we can have benefit of doing a PSA after age of 60. If more than 4, we think, then with the DRA examination.
This high processed meat and this refined flour, definitely it is causing malignancy. We can say that parota, definitely it's a, we think of, we say about the parota, but not only the parota, even the bread, it is a refined flour. So any material made of that refined flour may cause increase that cancer risk. Also the red meat like beef definitely increases. That may be the one reason, but we don't have a definite data to say this is the reason. But definitely it is increasing. Yeah, we are doing that. No. Definitely that doesn't has any role for the screening. It has importance when you are. Yeah, many of the.
If you, there's only, there is no evidence, that's the only reason, because if you look for the cancer screening anywhere, only PSA has got a role. AFP, once you have chronic liver disease, then only have some role. Now, once you have CLD, then AFP and CT, everything is coming at a role. So a screening purpose, asymptomatic patients without any evidence, the benefit of CA and AFP is not there. PSA is not, is there. That we can do, individualized patient we can do, but as a screening purpose, routinely we don't have, we can execute this. Only thing we can execute is self clinical box examination, yearly once clinician examination, mammography, or mammography is not available. Ultrasound is a good tool. Eye breast also, I have also advised for eye breast is a mass population, we can use eye breast. These are things we can do. Stool occult is a good tool, but stool occult is very, there are many false positive, false negative, then further investigation are going on. Better to do our system, colonoscopy, sigmoidoscopy, easy thing. Is available, everywhere is available.
That's for the small bowel. Yes.
So it is a very common disease. We always think, promote, activate, support the screening program. It's a very common disease. Once you did, maybe as a clinician, once you see the advanced stage of disease, cost is one issue, morbidity is issue, then late sequelae. So everything is an issue, because if you detect early, the 70% we can control. And cost effective screening is the important thing.
Vegetables we get in Kerala is too much having insecticides. Would that be the cause of CA colon?
That will be the same situation in every state. I don't know. I'm not an expert, but the same insecticide may be in every state, right, sir?
So
We read in newspapers and these Tamilians, they are exporting all vegetables insecticides to Kerala. They won't eat it. They won't take it. They are dumping everything in Kerala.
vegetables and fruit. Ideally, we take more vegetables and fruits, but to get a quality fruits and vegetables is difficult in Kerala. Initially, we are in our childhood days, everything is in our house. Correct, because G junction cancer, rectal cancer are coming in early age, 25, 30. G junction is very common, and rectal cancer is very common. These are no, initially they are seen after age of 50. When many patients are coming with the 25, 30 is very common age group now. Age population is changing, but initially after 50, now it is going to 35. So there is some issue in Kerala, something in our lifestyle factor, food habits, our changing food habits, because we totally change the food habits. Initially in our culture is what is natural food only, with additional some fish. Now totally shifted to different food habits. So now again shifted to new form of food habits. So it may have some impact on our disease. That is also, it is going on, but
come up with a small effort from our side. Sir and myself has come up with a system called OnCure. What we are doing here, we have to do the preventive health checkup with this cancer screening. That is already mentioned that the most of the executive checkup doesn't include that cancer screening. So we give more importance to cancer screening, and we have to come up with the early detection. That's why there's a small effort from our side. It's not an NGO. So it's a clinic system actually.
Small work. I don't think it is a small work.
Because in our health system, the government and NGO cannot come deep into the society. They are catering only the minor portion of the society. There is already evident from the other part of the disease that cancer and whatever the disease, it is mainly dealt by the private sector, and it's not by the government sector or the NGO side. So it has to come in the preventive aspect also. We know that when I also became a part of that Malabar Cancer Society multiple times, and I've gone for the camps. So only the low middle income people will come for the mass camp. The middle income or above middle income won't come to a mass campaign or a government supported program. It has to be in some other centers. They are comfortable with the screening. So it should be some private organization also. That means everybody should indulge in that cancer screening programs and the preventive aspect of their life. It's not when the disease become a major health issue, we have to intervene. At the initial stage, to prevent that and to guide them, we have to, every doctor has to involve, I think. Yes, sir. All these tests are being done. This is in Tana, near to Kannur, just above that DDRC building. Yeah, we will be associating with them also. And nearby institution also we have to associate. So it's a small venture. So let us see how it works in the society.
We are planning to conduct a second opinion in tumor board in the same group. Our aim is to conduct any patient who coming.
It was solely sir's idea that the concept of decentralization of the cancer care. What happens now, once the cancer is diagnosed, they are being sent to the cancer centers or the private institute. So what happened? Majority cannot afford, as sir said, majority cannot afford. So they has to be treated in their hospital itself, in the community hospital. So what has to do? They have to be guided how to treat. When there is a breast lump, how to do what's the next. So the panel of an expert oncologist can give suggestion to the periphery doctors or non-oncologists. You can do like this and you can manage. Many of the patients, maybe 50 to 60% of the patients maybe can be managed from the periphery hospital itself. No need to go for the higher centers. So the online tumor board with the experts across the globe will be there.
So one of our main aim is to, one is early detection, other is active tumor board. We are almost 25 25 oncologists, including medical, radiation, surgical oncologists are. They'll present on the online group. We have every day we have got one oncologist there in the evening, but we have got we can anytime they can go for an active tumor board discussion.
Regarding the election process, our secretary forgot to mention about the election of women's doctors wing. So one nomination is Dr. Leda as president of women's doctors wing, and Dr. Shweta Prasad as secretary of women's doctors wing. Okay, great. Now, vote of thanks by the joint secretary.
Thank you, Dr. P.K. Abdulla and Dr. K.V. Gangadharan for accepting the invitation of IMA Kannur. The message was very clear. It was an excellent and informative talk. Thank you, sir. Thank you, sir. And I thank every member who attended this meeting and actively participated in the discussion also. Thank you.